shot a BB gun,
Mm-hmm.
and it lodged up
Underneath?
and it was right next to his. It was right next to his eye,
Mm-hmm.
so it wasn't anywhere. And this is a long time ago.
Yeah.
And I called the ophthalmologist who said, "Oh yeah, you can send them to see us, but we don't remove them."
It's true. We often don't. So intraorbital foreign bodies, they're between the globe and the bone.
Yeah.
They're just in the fat. They often are left alone if they're not. Particularly if they're a BB. There's lots of BBs in orbits.
Walking around out
I'll just
there.
tell you that.
People up,
Perfect.
people
I'll
up
just tell
top.
you that the parents don't like that.
I know. Parents hate it. But I've got probably a dozen adults in my practice who are like, here's my BB. You know, it's been there since they were 15 or whatever. So you can go after them, but the problem is you typically have a little bit of scarring. They might have a little bit of strabismus related to going into the orbit to get this innocuous thing that no one wants. But it's so they can't. Obviously, we can remove them, but we generally are discouraged from it because no real upside.
Yeah. Okay.
Great.
All right.
So you ready to be a dummy?
Yeah. That's been my whole life, Mom.
So this is what we refer to as just a pressure patch. And give me some timing when we need to expedite or whatever, just for.
I might have to take off.
Yeah. We'll
Has
send.
nothing to do with you.
We'll have
I
the
think
pop
we're good
choice.
for now.
We'll have the pop choice quiz later. And I'll send it to your home.
Okay, yeah, text it to me. Okay, the answer.
So I would,
Okay.
if this were the eye, I just have him lean back. I would put a little ointment right there in the fornix. So just just kind of wipe that away.
Do we have
We don't-
erythromycin ointment?
Yeah.
Do we have the ointment here? Erythromycin ointment?
We have
One or
gentamicin ointment.
Oh, we have,
Okay.
we have one reason why I isn't.
Still,
Shall we
okay.
not?
So it'd be like,
Close. Just kind of put this on the eye. Have it close it down.
Do
It
you
full
ever
looks
use
like I put a
gentamicin?
couple of
Like
them
we got
there.
it up at Perk.
Maybe it's not
I've never
quite
used gentamicin for that.
I use it all the time.
thick
Okay.
enough. I just want it
Yeah.
to be
That's
thick
good.
enough
That's my
that
Like
go-to.
erythromycin.
pressure
Okay.
Yeah.
keeps keeps the eye from blinking. Can you blink underneath there?
No.
So and I'm not pushing on the eye hard. I just have a little bit of pressure. So then I might have him come up and hold it, or my staff come up and hold it. Just kind of hold it there. And then it's an hourglass. So the first one is just. You have to go to a lot of years of residency to learn how to patch the eye. And you always do it wrong, right? For the first year of your residency.
That's
So
right.
the first one is just on there. That's not really. There's no pressure there. Okay. 1 inch is a little better than 2 inch here. But now what you're doing is you're doing an hourglass. So you're starting here. You're holding it against his brow, and then you're pulling it this direction, and that's going to basically force it down on the eye. And you're going to do the same thing over here. You're going to go this way, and then come down like that, and you're basically just kind of mashing that down a little bit. You can't open his eye now. His cheek should be pulled up a little bit. Like he's got a little nice grin there.
Give
on
him
that
a nice
side.
facelift.
Yeah, exactly.
Just on one
And
side.
basically that's your pressure patch, and it's overnight, and he gets his food in it. That's it. And it's an ugly one.
and then you just tell them they can take it off.
Take it off
the next-
tomorrow.
Tomorrow.
Yeah. How do you feel?
Perfect.
Can you open the eye?
No.
So now the lid is closed and protecting it,
All right.
and they're good.
So you want it to bulk out.
You want it to bulk
pull
out.
out.
Because that's your
Because
pressure.
that,
Because
you're
it's
just
the
doing that
pull
little
back.
hourglass thing to kind of really kind of push it down and pull the cheek up a little bit and hold it on there.
Okay.
That's just a simple.
Nice.
Okay, now, this silly question, but it does happen. Women that come in wearing eye makeup
Yep.
during these procedures and whatnot, should we have them cleanse it off first before putting dressing, or does it matter?
I don't think
For
it
any type of
matters.
contaminant?
I don't think it matters.
Oh, okay.
I mean, it wouldn't hurt to wash it, but I don't think it matters
Okay.
in that regard. The worst part is just people who have big beards, can't ever get anything there,
Okay.
or they have really oily skin. And you're like, alcohol
Oh, so
scrub and trying to get them sticky enough or dry enough that you can stick something to it. Sometimes you can't. Obviously, what you don't want to do is have the eye open. So,
So would you patch a corneal abrasion?
Yeah.
Okay. Even if it's not a foreign body, it's just they came in, got whacked.
and you may just, if your comfort level, if you don't feel comfortable patching, don't patch. You know, but if you get comfortable with it,
It's more comfortable for the patient.
yes, it's much more comfortable.
Okay.
Okay.
Um,
Most corneal abrasions, or just some?
honestly, a lot of times we put bandage contacts on. just use a contact lens, and they're just like a low power, cheap contact that we throw in the eye and have them come back a week later and take it off. And they're wearing a contact, they're sleeping in the contact, so they're also on antibiotics. So we're just giving them precautions and telling them you got to come back and take that off. So those are the pretty small, relatively easy corneal abrasions. Someone that's got to work, that doesn't want to wear a patch all the time.
So how come we were told not to
never
patch eyes? Like that is like
The old
beaten
ER
into you,
treatment.
like to not patch eyes.
So I guess the patching concern with patching is if you don't patch appropriately, I guess is the concern. If you have an anesthetized cornea and you patch with you don't get that lid down fully. I wasn't part of your training, so I don't know why they would have said to you never patch eyes.
But
Yeah, I mean they
Mine was.
told us the ophthalmologists don't want us patching eyes like that. Like it was beaten into us as to like not patch eyes. Seriously.
I don't have an answer for that, but I may have to follow up with you, see
Yeah.
if there's something that I don't have any reason why you wouldn't patch, except that you're missing something. That in terms of patching, we want antibiotics on regularly. So I'm talking about specifically like a corneal burr and a deep wound,
Right.
and you're covering that up for comfort, and it's an overnight kind of thing. I don't see any other reason why you couldn't patch in that case.
Yeah, I think
Sounds
a
good.
12 or 24 hour. I feel like in
Like
residency
patched
they're
a
like,
month later.
yeah,
and-
that was the thing. It's like having people cover their eye for a month. Was
Well, I mean that's
Yeah.
the second postulate to that is that people are idiots and
Yeah.
right. So that,
And they
that's
don't do what
they don't do what they're
tell them
supposed to do, and then yeah.
You see them 6
I-
months later, ratty tape still lingering on.
I mean, I
it.
could see like you
It's
want
a little different color.
Yeah. No sunblock, suntan there. I could see the need for aggressive topical antibiotics if you're not getting potentially if you're
Okay.
patching too long or whatever. in that regard.
And I've heard not to patch a Bell's palsy because is that a similar logic? For a Bell's palsy, they can't close their eye and it's kind of perpetually open.
So Bell's palsy, the concern is exposure, keratitis. It means their seventh nerve, they can't protect their own cornea, right?
So you have to.
So we patch those.
Yeah.
Okay.
The patch
Yeah.
those.
But I've also heard not to patch that. I think it's the same
No,
kind
I've
of
always.
old
That's
school
the
logic.
one thing I've
Okay.
patched.
So
Okay.
you could also for like a corneal. I mean, the concern is desiccation of the cornea, just an ulcer that forms because they can't protect it. So you could just do every 2 hours ointment, and they would keep their cornea relatively moist. But as that Bell's palsy is recovering, then we're not patching. But initially, when they've got they're like this, the eye's not blinking at all.
Yeah.
It's
Yeah.
wide open. You're like, I'm patching that, And you have them patch, you have them do the ointment, you're aggressive, and then over time, as that's back up, then you can go to just topical ointments during the day. I don't do it enough to remember the term for suturing the eyelid closed. There's a term for that, not that you care, but there's a term for that.
That sounds fun.
Ooh.
We can do a temporary suture. It's a simple suture that just kind of closes the lid and keeps it closed. And my oculoplastics friends will do that. Instead of a
Not
carpet
something
patch.
for
Not something
taking
for
Not gonna train that one.
Yeah, not gonna do that one.
You're like, no.
Is there
Oh, pass it.
anything that you can do for a person who has welding keratitis for pain that is
It's legal.
that's legal?
Right.
I have one complaint against me with the state medical board, and it was a diluted proparacaine for this. I took proparacaine, I diluted it 10 to 1, which is what refractive surgeons do, LASIK surgeons will do. And patient went somewhere else. Afterwards, happened to be a competing practice in town after I left, but they reported me to the state medical board for inappropriate use of proparacaine, which the state medical board said this is stupid and moved on. But it did go on my record for 7 years, which is so stupid. So I don't think. I guess I learned my lesson. I don't know that there's an appropriate way. I think you can't. Patients will steal a proparacaine from your clinic as soon as they see the beauty
Feel it?
of Yeah, as soon as they have that pain recovered,
I grabbed
make
that.
sure that proparacaine is out of sight.
It's in your, yeah, that's
Yeah.
that one thing here is like making sure that it's not in the room.
I don't think
Does,
there's anything you
does
can do.
patching help?
It's doesn't really help
Doesn't,
a lot. Yeah, it's just ibuprofen and sleep it off and
Topical NSAIDs?
I don't do that,
Not
but
very helpful.
I don't know that that's.
I don't think anything
That's the only
helps
thing
these
I've
days.
ever heard is
Yeah.
some docs have told me to try topical NSAIDs, but
Yeah,
I've never seen somebody that's excited about it.
yeah.
They usually just go and cry on their couch for a couple days and get back after it.
And then you wear their visor.
You
Yeah,
would
too.
think
Every
that they
time,
would wear
yeah.
their visor every time after that, but I have seen repeat customers.
Yeah.
What was
Yeah.
she just saying? People
How
are
many-
idiots.
How
Yeah,
many
exactly.
times
First
do you-
postulate.
I'm like, are you my son?
Yeah, exactly. Okay. What's the next topic? I know we're gonna stop about 9 p.m. tonight. Is that right? Just kidding.
Iritis would be great.
Oh, you put it.
Understand iritis.
So do I actually.
Iritis?
Iritis would be great. An overview of that.
Tell us, so, you wanna talk about it just globally? Do you wanna talk about certain questions about it? What are you thinking?
Yeah, just when it should be high on our differential and how do we manage it?
It's always there. It's always on every differential for a red eye. And we tend to just think most red eyes are conjunctivitis or some surface-related pathology. But a lot of times it's the ciliary flush. It's the actual, the eye itself is just upset from whatever other issues are going on. It's the canary in the mine shaft. Uveitis is so prevalent in patients that have all kinds of autoimmune conditions. We see a lot of it, and many times they're undiagnosed. They don't know they've got irritable bowel disease or Sjogren's or whatever else they're dealing with. They're just years of these intermittent episodes of red eye. So the big things for us are when you start to see irregular pupils. You start to see that irregular pupil, which have you seen those? Yeah, you start to see synechia is what the term is for us. This is just synechial closure. You start to see enough inflammation that the iris is getting stuck, getting sticky, getting stuck against the lens below it or against the cornea above it. Obviously, if you're getting just these little, what do you call them, KPs, keratic precipitates that are there on the cornea. Anytime there's significant vision loss associated with it, anytime there's out of proportion photosensitivity, they're just like, just can't get out, having really severe pain. These are all, when we first see them, they're all like just an idiopathic. We don't know exactly what's causing it. We're going to send them for everything, syphilis, TB, toxo. We're going to send serology for everything just to rule it out. But the approach is always the same. It's very aggressive steroid, up to Q1 hour topical, and then it's more potent topical steroids than just penicillin acetate. It's some of the stronger stuff, and it's atropine. It's just try to pull that pupil apart. You're not just trying to do synechiolisis or breaking it. You're really trying to just paralyze the pupil so that they're not so sensitive to the light. The pupil isn't having to move every time they see light. So I don't think anyone's expecting you to do a workup for uveitis. I think anytime you see a red eye that's got a little more light sensitivity than you would expect, and you see any intersegment concerns, someone said I've never seen cellular flare in the anterior chamber. I didn't see it either for like the first year of residency, so it's pretty normal. Just takes a long time. You should be high mag. You should be off axis. You should bring that beam down real small, and you're just looking for dust coming through that column of light in your house. That's all you're looking at. You're just looking for fine cellular debris through that column. And if you can see it, there's probably some significant flare there and cell there. Flare is, of course, just you can see the entire column, and cell is the actual or white blood cells that you're seeing there. So usually we're not gonna, just like we said before, we don't want you to put them on aggressive topical steroids because we want to see it. If your cornea is completely clear, you're 100% certain there's no little HSV dendrite over here that you missed, and the patient is, you know, Crohn's disease, and this is their 4th flare, maybe you're more comfortable saying, I know what I'm treating. This is definitely uveitis. Patient tells you, I keep a little bottle of Pred Forte in my bedroom. Many times they do. They don't come and see us.
So I had one recently.
Yeah. They don't come and see us. They treat their flares on their own, you know, and whatever. Then maybe you're comfortable. You never heard this. This isn't on record. Maybe you're comfortable treating with topicals, but you just have to be really careful with that. And so, I think your question about when, you know, what do you do in the primary care setting? What do you do? What do you do? Yeah, call us. You just get them in. I think that's the most appropriate thing to do. And first case, we don't typically do the big workup. We're not going to send them for quantiferon gold and FTABS and all that stuff. First case, because it's just first time. That's just not the indication. But if it's a recurrent flare, then we go back and we start talking to the rest of their team and saying what's going on. I saw my first neurosyphilis in the eye like about a month ago. Seen it plenty of cases. Aztec gentleman came up my age and had loss of vision in one eye and field loss in the other, and we do an little ocular CT, computed tomography, and to look at the retina, and it was just all trashed, and this big white plaque on his retina, and I just was outside I hadn't seen this presentation. I'd seen other stages of this presentation in journals and meetings, and I said, we're just gonna have to rule everything out. I need to send you for all these various things. And he started sharing a little bit of his lifestyle with me, and I was like, this is not good, bro. This is not good. You've lost an eye, you're probably gonna lose the other, and if it's here, it's in your brain. And so I got in touch with Brooke, and who's my neighbor, and she put him on Pen-G. He got that eye back.
Wow, that's great.
He got his primary eye back. He was treated just relatively in that early time frame, and amazing.
Wow.
So I guess, but syphilis is a huge masquerade.
Syphilis is
and
on
syphilis
the
is
rise.
crazy.
It is kind of crazy
And
right
so
now.
is TB.
Right.
TB, with all of our native patients, we have so much TB in our clinics, and we're right there at their faces.
Yeah,
and,
right.
Yeah.
without our masks, you know. So I guess that's the question about uveitis. Just when you're concerned enough, you get them in to be seen. Sorry, that wasn't very helpful.
No, that's helpful.
What to do in a care setting. Questions about uveitis? Do you want to delve into like iritis versus panuveitis versus? No. Hey, thanks, Sarah.
I've got a quick question on just like a corneal ulcer
Mm-hmm.
with a ciliary flush, but no signs of uveitis other than this.
Yeah, so you get depends on it. If you get an ulcer that's close to the ciliary and you'll get a sclerouveitis. It's a localized inflammation, infection, possibly infectious, all along that area. Just with that, your body reacting, sending everything into that area.
But what if the ciliary flush is
Everywhere
circumferential?
around it.
Yeah.
Just an indication that it's more severe.
Yeah.
And you can get a uveitis secondary to, a keratitis.
Okay.
So if they start to really thin, or they start to have scleral melt adjacent to it just from aggressive immune response, and, I'm punting that to my cornea friends in Albuquerque. I'm not managing that.
And then what about a culture on a corneal ulcer? Do you routinely get them? Or?
I don't.
Okay.
So technically, you should scrape before an antibiotic ever gets placed on that eye. Plate it, which we did in our residency. Send it.
Okay.
Never do it. So a little calcium alginate swab. You guys have those? What do you guys culture with, like throats? You have a little
Just
little thing that goes into its own culture.
yeah,
medium?
yeah. The white.
So that's what we'll do. Honestly, most of the time they come to us already having been antibiotics on board, which doesn't help us a whole lot. But I'll just gently do this with my calcium alginate swab or topical, and I'll stick in that medium and I'll send it off to make sure I did. Because 3 months later, when it's fungal and you've thought you were treating it and whatever, and someone asks, "Did you culture?" No, I didn't. I just threw them on antibiotics. I was sure that's what it was. So I tend to clinically in practice, but I don't truthfully trust it a lot. And If they're not responding to broad spectrum, I'm punting myself to the cornea doc most of the time. Not very helpful, but it's
Now, if they do
That's
that,
fine.
they return to us because they're not getting better. Okay, they always do. Do we send to you, or do we
I would.
jump to specialist or to the corneal, or what?
So I would send to a general ophthalmologist for most of it,
Okay.
honestly. I've shared with you that we send a lot to cornea. It's not that much. It's just when you're like at that level of like, this is not getting better. It's not improving like I want it to, and I don't want to be sitting on this when your cornea melts. Then we send you to someone. Okay. What else about uveitis? No, you were scratching your cheek. I thought you were asking a question.
Me? No.
Yeah.
No, can't.
I'm at your disposal. You want to keep going? You one or two more?
Well, I think one of the questions that I get all the time from people is that you have floaters, and how it's the question that Amanda had. You know, it's the Friday of a holiday weekend,
Yep.
and how long can they wait? When do they need to be seen? That's really
So
how
it's a
soon,
great one. It's a really good one. It's the low back pain of our practice.
right?
You see it all the time. And we are not as interested in seeing it as you are. Like, it's in your chair. You want it out of your chair tomorrow, and we're like, oh wait, it's fine. You know. So flashes and floaters, they just don't progress as quickly as the public's understanding of it is. So people tend to think flashes and floaters, come see that, got to see that retina doctor tomorrow just in case it's detaching. Well, it's true. That they may be in the process of detachment, but it's not a rapid process. If they come into you and they've got a big scotoma, okay, they're detached. It's moving, it's progressing, you know. But if they've got flashes and floaters, well, there's a 10% chance flashes and floaters are a tear or a detachment. 90% of the time, it's just a vitreous separation. And you're all familiar with vitreous separation pathology, correct? Are you? Or would you want to talk
I'm
about
not.
it?
Sorry.
I'm sorry, I shouldn't. That's a terrible question to ask. You're all familiar, right? And I made you just say, I don't know.
Put you on the
Sorry,
spot
don't
over
know.
here, Carl.
I lectured by my eye doctor about it just the other day.
What's that?
Oh, my eye doctor's telling me all about it the other day.
Did you get one?
No, she was
Yeah.
telling me about the biphasic, and so I had the first couple a few years ago.
Yeah.
And she's like, "You're good till you're 60, then they'll start happening like crazy." I was like, "Oh wow."
Pleasure
You
ciliary
have so much hope.
bodies.
It's all downhill.
And all this gel is nice and adherent
Your
most
arm's
of our
getting
life
tired. You want me to
to
do
the
it
back
for a
of
little
our
bit?
eye, right?
Sure.
It's one formed body. This vitreous body. It's like a tadpole sac you saw in the creek when you were growing up. It's like this little membrane around the outside of it called the hyaloid, and it fills the whole volume of the eye. And then as we get a little older, it pulls away from the back of your eye. It just kind of comes forward. It just contracts a little bit and pulls away from the back of the eye. And in that, and there's a moment where it pops. It's tugging, tugging, tugging. We can see it on our scans where it's lifting slowly over time. When it pops free, once it pops free, we call that a PVD, posterior vitreous detachment. And it pops free up to about right here, kind of mid-vitreous, or about halfway out. And then there's this little ring floating over there where it used to be over the optic nerve, little Weiss ring, and they see that ring, and they're so ticked about this C-shaped ring that's floating around right over their visual axis. So pretty frustrating. But as it's separating, it's tugging on the retina, tenting it and tugging it. And that's what's causing that pathophysiology of the flash. Your retina doesn't sense any pain, only light. So as it's separating, it's slowly just creating this potential space that used to be there is now a new space, and it's slowly separating. And every once in a while, it'll just pull enough to pull a tear in the retina, 10% of the time. So 9 of those 10 referrals we get are worried people who have new PVD, and they have to be seen. They do have to be seen. And they typically need to be seen within a couple days to a week or so, generally, for new flashes and floaters. And then a fraction of them will have, if you're looking at the retina on FOS, or whatever we say, like this, like here's your optic nerve, and here's your fovea, we'll see a little tiny horseshoe tear out there on the edge, where it just tore. as it's coming out. And then there's a little fluid pocket there, and then a fluid pocket, and then they're detached, right? And it starts to separate. And about the time it's mid-vitreous here, they're like trying to find what they're missing in their field of view, because they can now tell they're missing something in their field of view. And they might still have some flashes, or the flashes have gone by then. And then slowly, the fluid inside the eye gets below this little opening. You know, the fluid's going underneath there, and that layer just kind of separates. That's the detachment. So that's the pathophysiology of a PVD. So most of the flashes are just vitreous traction. Most of the floaters are just the gel moving around in the eye. Okay. When it separates as we get old, instead of being one solid protein collagen mass, it's now, some of it's liquefied, some of it's hard. You know, it's like just little boogers floating around the eye. People get frustrated about it, but most of the time it just settles down to the bottom, and they see it when they have a saccadic movement of the eye, and they'll see it a little bit. And some personalities are bothered more than others. Some occupations are more bothered than others. But so that's a PVD. When to send it, they should all be seen. They should all see someone. They can see their optometrist, they can see a retina specialist, they can see an ophthalmologist. In the retina world, because we repair them, because we're examining them all the time, we catch things a little earlier, smaller breaks than some of our colleagues. We can't see everybody, so it's just, you should see someone, and if they're concerned, then they can refer you on to us. So I think when to see a PVD, next business day, or within a couple of days. It's reasonable.
Okay.
Questions about that? No. Okay. I guess if it's a detachment, I would always do a confrontational visual field and document that. And you guys do all your fields are probably pretty similar, but I mean my basic. I mean, you use my exam. I try to get just to their level with me in the exam room, and I'll have to say close your right eye. I'll just close my same eye, and so we have the same basic visual field in this eye, and I'll just, how many am I holding up?
One.
Don't cheat, don't look at it,
One.
switch eyes, same thing. You know, just kind of a gross confrontational visual field. Someone at their level, if they're like, no, I can't see your hand, and you can't see your hand, well, that's because your hand's right. So, just kind of just get it.
I see it, I can't see it either.
No, we're both detached.
Exactly.